What if you have a patient that has a high smile line? And that used to be an indication in my mind, you shouldn't do FP1 because you don't want the gums to be visible, right? We're supposed to hide our work, right? But one thing I've been sold on with you guys is that no, you don't. That does not mean you need to do FP3. In fact, that's one of the worst things you could do because now you're going to be removing even more.
Welcome to another episode of the 3 on 6 podcast with Dr. Randy Roberts.
Education, empowerment, starting now.
Hello, and welcome to a very special edition of the Fix podcast, one of our first crossovers with
Dr. Randy Roberts and the 3 on 6 podcast with
Dr. Logan Locke.
Dr. Soren Paape.
Dr. Caleb Stott. Yeah, this guy.
Yeah, so this is Fixed on 6. And so here we are, the regular Fix podcast guys, and we've come out to this course to, learn what all the fuss is about when it comes to 3 on 6. We've talked a little bit about FP1 modalities on our show before. We've always been a little bit wary of it, more so out of concern for a lot of things that we've already talked about. If you got a high smile line, you got, implant failure being harder to take care of, higher patient expectations perhaps, all kinds of things, gum recession. All these things, have really kept us away from that type of modality for a long time, but we've been seeing this 3 on 6 stuff for so long. Of course, we've had Dr. Locke and Dr. Roberts on the show before, and now we're really getting to see, how the sausage is made, right? We've been in the clinic, we've been looking at their post-ops, looking at their deliveries, learning the whole surgical process. We'll actually be doing surgery tomorrow. Of course, we're going to talk about that eventually. And we're here to share a little bit about why all the folks, we have a very large audience of people that are doing tons of FP3s, tons of implantology, why they might need to open their eyes a little bit to what's going on here. So I'd really appreciate it, guys, if you could give us a little bit of background about what 3 on 6 is for those that are uninitiated and what it's become at this point and what it means potentially for providers.
Okay. Well, I'll start. I feel like the reason that you guys are interested and potentially other doctors is really because the patients are driving this. It's something that as we've been doing it and getting good results, our patients are so excited and happy that they found this and that it's at a reasonable price. And they're like, how did I not know about this? I almost did the other thing and there was no coming back from that. And when they got this and they found out that it was like having teeth in their mouth again, and so they become so excited about it and like trying to tell the world, they're like, no, you have to do this. Like this, I didn't know, and I almost did that too. And so we've got these cheerleaders that are going around, and a lot of doctors like you guys are finding out about it and finding out the extent of how much patients love this from the patients. And it's like I've been trying to tell people I think it's better for many years, and people are like, Dr. Roberts, we're pretty sure you're done. And and maybe they're right, I don't know. But my patients, and Dr. Locke's patients and the 3 on 6 patients around the country that are getting it done from our providers, they're so excited and so happy about what they're getting.
We love when we get doctors that come to the course because patients are pushing them. And those are the best kind of doctors because they're looking out for the interests of their patients. They hear it in their offices, and we love to know that they're hearing it in their offices. And so to get doctors that come out because patients are driving that is a huge testament to what 3 on 6 is and how much patients love it, just like Dr. Roberts said.
Yeah, I think it's very important for clinicians to have just different options for patients, right? In our office, we do a lot of FP3. That's kind of typically what we're doing. And a lot of the patients that are coming in to our offices for the treatment, they are at a place that maybe they've been in a denture for like 20 years, and doing an FP3 is totally comfortable. But those patients who maybe are a little bit younger, in their 40s, who still have that good bone, and they aren't in a situation where, we need to remove all of that bone, it's a wonderful option to provide. And ultimately, it's going to come down to the patient's decision, what their goal is, if they're looking for function or aesthetics or whatnot. However, being able to offer, that treatment to the patients and give them the option of, hey, you can have an FP3, maybe it's a little bit cheaper for you, or if you want this FP1 based prosthetic, it is going to be thinner, maybe have less like sound when they're coming together, feel a little bit more natural, but it will be a little bit more expensive. And then give that patient the choice and let them decide.
Yeah, I definitely like that it's a higher order of service, right? And it also helps set some expectations. even if someone does eventually go down the FP3 road, maybe due to finances, they understand that there was a road that they chose not to go down that may have given them that more natural feel. They may have not had some of the phonetic issues they deal with. Maybe it would have been a little bit less accommodation. So at least they're primed to understand that they didn't choose to go that way. And now that they're choosing a path where there will be some more accommodation, maybe they are going to have some bone removed, right? Like they can kind of, it's allowing them to choose that path and not just having them, face those sorts of consequences later on. I definitely think that where a lot of friction has come about in the conversation between FP3 versus FP1 versus 3-on-6, whatever, comes from this sort of either or mentality that one or the other is somehow just better for everybody. I don't necessarily think that's true. And I will say that I have been very impressed and humbled by some of the cases that you guys have been able to fit in this 3-on-6 box, because some of the ones I've seen I would never have predicted would have done that. But I think that we have to see a world where these two things can coexist, and there are appropriate situations for different patients. And there is also a financial reality of it as well. Like 3-on-6 shouldn't be as cheap as on-X. It shouldn't, because it's definitely not the same thing. I mean, and frankly, it's just not, all of us know this, is there's just not nearly as much orchestration that has to go into doing it all in this case. Like if you are capable of laying a flap, finding bone, and just putting it in relatively the right spots with the right sort of timing and things like that, you can be very successful, and the lab will do a whole lot of work to make that case a slam dunk. With this, it does not work that way. You don't just walk in without really knowing that case. And you have to know every extraction, every tooth is going to be used as a fiducial, every implant size, where you're trying to come out, exactly what kind of correction you're getting, because your access holes are going to have to be money for this to really make sense,
Yeah, you don't give yourself enough credit as far as the FP3 side of things goes, because Randy and I see a lot of cases come in, and I know, and I've seen a lot of what you guys are putting out, and it's on the scale of FP3 side of things, I think it's the most stable, some of the best stuff that's out there.
Appreciate it.
But it's a different world, and it's a really rewarding field to be in. And you guys, as part of this training, we have been seeing a lot of live patients that came through our last training, and you've seen that it's fairly predictable. I mean, we had 3 final seats today, and all 3 of them, they're not cherry picked by any stretch of the imagination, and they look good. Patients are ecstatic with the results, and it's something that can be done predictably if kind of the recipe is followed.
And that's something that a lot of the doctors that have come through our course have said that they've never seen before, that they got to actually just see the patients that were on the schedule for that normal time to just get the normal work done, right? Normally doctors are only cherry picking patients and being like, oh, come look at this patient. Okay, here's the patient that's on our schedule. We're going to seat their teeth on, or we're going to take their scans just because this is when they're scheduled for it.
Right.
Yeah.
And so you got to see 3 of those patients that had beautiful teeth and beautiful tissue, and that have, and the first 2 actually were from training. So those are from doctors that were just learning how to do it.
Yeah.
Last time with a beautiful result.
I think it's important too, because we got to see, how you guys manage certain not necessarily complications, right? But like, if a bridge isn't seating exactly properly, like what are the processes that you guys are taking to make sure that seats? And every dentist, no matter what treatment you're doing, but especially these full mouth cases, you're going to run into those little things, and those little things are what can make like a seating appointment that's supposed to take 30 minutes turn into like an hour and a half, 2 hours.
Yeah.
But if you catch these little like gold nugget tips and see how you guys are seating these segmented bridges, it does go a really long way for the doctors to ensure that they're feeling comfortable when they're doing, not only their surgery appointment, but also that post-op care.
Yeah. Yeah, and I think one thing too is, especially talking about the deliveries and like how you maneuver these types of things, not only is it different because you're working with a segmented bridge, but something we've also been able to see here, which is somewhat fairly new in our spaces, maybe not new, but it's new again, is the direct to fixture aspect of it, like taking out the multi-unit. That's something that I had no clue, I kind of went straight into all on X and using multi-unit and restoring at a multi-unit level. And I do some single unit stuff, some bridges here and there, but it's never really been my huge forte. And now this whole case is it's FP1 direct to fixture. How do you navigate a full mouth of that? And for me, that was very, very intimidating. I'm seeing how you're able to make it more predictable. but I'm also seeing why, a system like TRI potentially makes this a whole lot simpler, right? Especially when it comes to the timing aspect of things. That's another thing I was very concerned about, is like in how you make these cases work. And doing that direct to fixture that has its own internal angle correction seems to have made that a little simpler for you guys. So I think that's where a lot of us have been humbled and trying to work through that and learn what that might look like. If maybe that is the best way to do this type of case. Yeah.
And that's something we work heavily on, and we see so many of these patients, and Randy does a great job at putting in the time and researching different ways to make the process simpler and to make the results better and to get thicker tissue around the implants. And he's doing this stuff while I'm trying to figure out, okay, how do I simplify it so we can train the doctors? And then once I start seeing his pictures, really it's me going in and being like, oh, this looks really good. Like this is looking better than my cases. It's time to implement this new thing into what I'm doing and to what we're pushing out to all of our doctors. And I think that's one of the great things about 3-on-6 is it is a constant work in progress, and we are just trying to push the limits on what we can do as far as FP1 goes. And we're constantly trying to make it simpler for our doctors and more predictable for our patients and on our fan clubs that are out there, that they're getting the same result, in Boise that they're going to get here in Salt Lake, so they can stay at home.
One thing I noticed, like my biggest takeaway from being here with you guys is you're not afraid of innovation, right? That's what you're talking about. Where we came and you have multiple different implant brands, you have like every single type of photogrammetry unit, you have different scanners, you have all the different lasers. Like really, if you wanted a tour or to go through a museum of all the different things that have been involved, like in dentistry, then you could walk back here. I swear that you probably have like a pedal drill somewhere back here. So, and I think it takes a lot of humility to do that. A lot of our mentors, right? As we go through and kind of learn this, and there's been evolutions of this throughout time, they're really stuck in their way. And maybe it's not for the worst, but sometimes it's not for the best. And you get a lot of, nobody's really accepted when you're the only one talking about something. Yeah. And I bet Randy's had to deal with a lot of that throughout your career. Sure. But with time and with experience, you're proving what's possible and you're pushing limits. And these limits are better for patients in a lot of ways. I know there's a lot of patients that I've had that have received really good treatments given the information that I had at the time. But there's also some that could have benefited from 3-on-6 so much more than just, doing 6 implants and having pterygoids and stuff like that. So that's been my biggest takeaway is humility, innovation, never afraid to reassess what you're doing. And it's not about you. Like with a lot of instructors out there, it's actually more about the ego than it is about the process or the patient. And with you guys, I can definitely feel that it's not about you. It's more about your patients 100%. I loved seeing that.
Yeah, and we love bringing on doctors like you guys because we always feel like we can do better and we can be better. And when we bring on awesome doctors, like you guys are always also being like our conversation earlier, like with taxes and stuff like that. And you're like, we can help you out in these different ways. And it's like, and also there's different ways and also with the surgeries and different things where our doctors help us out and we all kind of grow together. I feel like this is a big family. And like you said, we're trying not to have egos and we're just trying to all work together and figure out how we can make the best products that we can for our patients.
Yeah. And ultimately that's what it comes down to is just creating the skill so that we can treat our patients with the best possible care, and when they come to our offices, like I see patients all the time that, and we talked about this a little bit earlier, Randy, but they go to like the cheapest provider on the block just because of the cost. And they just don't understand that. And it's difficult we try to put out content on our YouTube and whatever to portray to our patients like, hey, everything is not all the same. It's not just like you're going to get implants placed the exact same way every single place. Maybe it feels like that for the first year or two, but once those implants start, degrading a little bit, you're in a situation where that treatment cost that you saved is going to end up costing you a heck of a lot more when you go and have to have it redone. So it's important for patients too to listen to stuff like this, right? Or for us to give that education to our patients so they understand that, hey, maybe don't fly to Mexico or fly, to wherever it is to get this treatment done, not because there isn't great doctors there, but because it's harder to determine what is a good provider and what isn't in these other countries. And ultimately, I know plenty of great providers in these other areas. However, if you go to somebody who's been to like 3-on-6, been to Orca, been to a lot of these courses, you'll know that you're going to a solid clinician that has spent the time on the weekends where they could be doing other stuff to excel and be a better clinician.
Well, I think something that you guys have done that's so impressive is when we first started Smile Now, we identified that, across the market of all-in-X providers, there's a race to the bottom happening. And I think there's a lot of assumptions being made about these patients that really aren't fair. And it's that, they're bargain vendors, right? They price shop. They're looking for the cheapest number. They'll go to the lowest number that they can see. And that's why we're seeing some of these cases that are being done for $8,000, $10,000 in arch or something. And people are going way out of their way to just get the cheapest possible thing. And we try so hard on our content side to really build value and make people understand that it's, you don't buy a chicken sandwich at Wendy's and Chick-fil-A and expect the same product, right? And what you guys have done has shown that this patient base, there is a very significant contingent that is willing to spend more money for value.
Yeah.
If it's something different and they know it's something unique, they will go for that. And they are coming from literally all over the world to come get this done. And you guys have really shown the value of what you're doing. And these are very well educated patients. They've done their research. They're not dumb. They have really gone through Reddit, through Facebook. They've learned so much about implantology, right?
More than us sometimes.
Sometimes they have to ask a question. I'm like, I might need to chat this in the other room. And they do appreciate value. And so I think that it really brings a charge to full arch providers around the country to ask themselves, how can I convey value and value what it is that I do and not just feel like I just have to keep doing this for less and less money over time? Because that, of course, is a self-limiting belief. That cannot, persevere through time. And so, it really sold me that not only is it a value for a provider to come here and learn how to do this kind of thing, but patients will see that and they will value. And it's much easier to do that when there's something like that, right? When there's something like 3-on-6 that can then vet and validate you as a doctor that can provide it. And two, what I've been surprised on, and I think that a limiting belief that a lot of people that see 3-on-6 will have, is that some of this is cherry picked. Anybody can take a photo of their best case and put it on Facebook and say, hey, look what I did, right? But that is not what's happening here. I mean, you guys have done over 1,000 of these. We've seen these patients coming in and out. They're not cherry picked. We've seen things that maybe weren't totally perfect and need to be worked on, but you're getting to this result and these photos very particularly. I mean, I saw your phone, right?
Yeah, we pop up the phone on the screen and it's,
I see your
just go to
cases.
the last week.
It's very consistent. And it's, I think Danny Domain said this in one of his talks over ICUI or something like that. It's like, don't show me your best case, show me your last one. And I know both of you can show us your last case and it's going to match that same quality, the same stuff you post on Facebook. So there is a system to do this for patients and there are patients that do value this. So that calculus should show you as a provider that there is something here that you should at least give some time.
Well, thank you. Yeah, it's definitely been a journey to get to where we're at right now, where we're getting these predictable results and so many different techniques, like the one that, I don't know, I feel like I've gotten so much crap over all these different things. I'll go on different Facebook groups and I'll say, hey, healing tissue by secondary intention is really helping me to grow a lot of tissue. And everybody's like, what are you talking about? I'm like, I'm just saying what I noticed when I'm doing it this way.
Yeah.
Right. And it's all these people giving me so much crap. I'm like, yeah, I won't share what I'm learning with you guys if you're all going to be pissed at me for sharing.
Right.
But I feel like I've gotten so much of that. But anyways, it's been a journey is what I'm saying.
Yeah.
To get to this point where we're getting predictable, beautiful results. And it's required, I don't know, you've seen there's probably 1,000 things that Logan taught you over the week.
Yeah.
So many little tiny things that all add up to one thing, right? But if you miss any of those little tiny things, then the final result is off a little bit. Each one of those things makes a little bit of a difference. Yeah. So it's just it's awesome to be where we're at right now, but it's been a long and hard journey to get here.
For sure. And I'll say too, something that we've been very cautious of is when we place our implants, we want to make sure our patients are getting the thinnest prosthetic possible. With our FP3 cases, that's always been a huge philosophy of ours. When you have a patient that's class 2, angling the upper implants back and the lower ones forward to kind of correct that and make sure that that FP3 they're getting is incredibly thin. But we've taken a lot of time to learn how to angle our implants properly and do those things in our offices. And something that I see a lot in coming here, we also got a lot of tips for how you guys do that to make your prosthetics as well. But I think something that a lot of doctors need to improve on is to think about their implant placements prosthetically, not just where maybe there's the most amount of bone, but what's the most comfort for patients while also considering the amount of bone. And coming to a course like this is going to kind of open their eyes to the abilities of, we don't want to be looting a denture in this patient's mouth. Yeah. They're not paying $40, $50, $60,000 to just have this big hunk of zirconia, stabilize in their mouth. They're paying for that to have a functional set of teeth, a body part that's as close to what they had previously as we can provide. So that's something that I think is really, really important that I want more clinicians to really consider when they're treating these patients. Because ultimately, any clinician that's doing this procedure, it is kind of the visual of all on 4, all on 6, 3 on 6 for the whole culture. And we want to make sure that every provider that's doing these does them well, and taking time to come to courses like this so providers can learn how to improve and make their prosthetics thinner for the patients is going to go a really long way, not only for that clinician's abilities, but also the industry as a whole, to ensure that patients understand that the difference between a denture and a prosthetic is incredibly valuable, right? And the difference between a set of teeth and that truck they were going to buy, right? Yeah. It's more important to get that set of teeth.
And I also feel like it's really important that all of the doctors who are placing FP3 also can do FP1 so that they can give that, or at least tell their patients that that's an option. Yeah. Because I feel like if they don't know how to do FP1, they're not going to give it as an option. Their only option will be FP3, which means even if they have a 29-year-old with perfect bone and tissue, they say, well, your teeth need to go. The option are dentures or FP3, and we're gonna have to chop away your bone. And so without even being able to tell them, there is an option where we can give you a full month of implants and save your bone and your tissue. I feel like that needs to happen. I feel like that needs to be part of the conversation. Yeah. And so I think that if that patient finds out that this was something that exists the day after surgery and they're like, hold on a second, I could have had that when this happened, then I think that doctor potentially could be in trouble with that patient. And so I just feel like it's important for doctors to be able to at least give that as an option, or at least let them know that that's available in the market if it's not something that they're able to do.
Following up on that, like where would you rank the way that you guys teach about how to do FP1? Where would you rank that if there was a hierarchy of difficulty of different types of implants, right? So we have just traditional, and then you have like pterygoid, you have zygomatic, you have FP3. Where would you rank what you do in comparison to those?
It's funny watching it because I've had the blessing to watch some really talented surgeons do some really beautiful FP3 and quad zygos, and you guys with pterygoids, there's some finesse to all of it. And so I don't know that one is necessarily, watching that is a difficult thing, and you have to deal with difficult complications. But I do feel like FP1 has a certain finesse to it. And
artistry, and it requires artistry
and a lot of planning and a little bit more background in all of the things to be able to accomplish it perfectly. Yeah. We talk about atraumatic extractions and being able to get the teeth out without breaking bone and starting there. So we have to start teaching at the, something that most doctors are very familiar with, but maybe not as careful as we have to be in order to get the best results possible. And then we go through, the planning and the guides and how to seat a guide and spending the time to do that. And so there's a finesse to it. And then tissue management, which is a little bit more important than FP3 in most cases. And so I would put it up there, but I think, watching you guys do your work as well, that's complicated too. And you have to go through a lot of training to be able to do those remote anchorage, to do the kind of stuff you're doing as well.
I will say that, in my opinion, kind of going off of your question, is that, doctors definitely can provide FP1. Like if they have good fixed, all on 4 based treatment, I think FP1 is a great next step. I would prefer to have the ability to do FP1 guided in my office before jumping into zygomatic and these crazy remote anchorage based techniques, because, a lot of the reason that doctors go to do those remote anchorage techniques is to open their office up to more potential patients, right? But those more potential patients that you're opening your office up to come with a lot of headache, a lot of complications that that provider might not be fully prepared to handle. Whereas going from, just traditional all-on-4 FP3 to like guided FP1, that's a pretty easy jump. And it's going to mean a lot more care about tissue and focusing on these things, which then is a good accelerant to doing like Zygo and some of these other cases where you might not think about it, right? It feels more macro level, but ultimately you're going to have oral antral communications. You're going to have issues with tissue that you need to solve. So I feel like that would kind of be what I would recommend is, like we always say, get really good at basic surgery or regular dentures, then snap-ins, then your most basic all-on-4, then maybe like a little bit more challenging all-on-4 so you can solve some of those implant failures, palatal approach, pterygoids. But then jumping into FP1 is where I would personally jump to prior to getting into like transsinus and zygomatic and some of these crazy surgical techniques.
Yeah, I think often it's one of the biggest concerns we hear a lot is the complications of FP1 because we're dealing in an aesthetic zone and there's not a lot that you can hide. But overall, the complications for us are fairly minimal. And
if you do them, like you said, with all the little tips.
Yeah, if you do them the right way and you're preparing yourself for the future, then, some of our biggest complications are an implant fails, we take it out, and we do a new prosthetic over 5 implants instead of 6. Or we take it out and we shift it and we make a new prosthetic.
Or the teeth are slightly longer, and I think that's one of the things that most doctors are afraid of. They're like, what if I do it and the teeth are a little bit longer? And in my experience, I've had a ton of patients whose teeth are slightly longer in some areas than others. And even some of the ones that I post to people, and I'm like, they'll say those look beautiful and probably won't notice that canine's a millimeter or 2 longer than the other canine because it has a little bit more tissue or whatever. And it's not necessarily a huge complication because most people's natural dentition looks like that. They don't have perfectly exact same tissue heights on every single tooth. And so if it's slightly off, not that big of a deal because you still have all of the advantages of your teeth being so much thinner, so much easier to clean. So for me personally, I think that I think that the doctors should be learning this before doing the FP3s just because I think that worst case scenario, they just have longer teeth that are still narrow that feel more comfortable. Like it just might not look as natural for the doctors doing it their first time. Like maybe they'll break off more of that buccal bone and maybe the gums aren't going to look as perfect. In my experience, the patients don't super care most of the time that their gums looks perfect. They care that their smile looks really good. And your gums don't most of the time really show all that much. Mm-hmm. So making sure, and that's one of the things that the lab is taking care of for you, making sure that the smile looks really good, and making sure that the gums look perfect, that's more on the doctor. And the newer doctors are probably going to have less perfect gums than the doctors that have more experience.
Yeah.
But even still, I think that that's something that they'll have to start learning at some point. And having that restoration be so much narrower has so many advantages that I'd rather have them be starting there than starting with the FP3.
Something that I think is, kind of the trend, right, is as a person goes through their progression as a surgeon is, especially in the FP3 world, it's always like you're getting more advanced as you take cases on that have less bone available, right? It's always, how do I make FP3 work when there's less and less? So, what if we don't have zone 2 bone, right? What if we don't have a whole lot of zone 1 bone? What if this area is super thin, whatever? Let's go to a pterygoid, let's go to a zygo, let's deal with less and less and less. And you know what? That is a growing problem because we keep approaching all these cases with an FP3 mentality and we keep hacking a lot of bone away, right? Well, what if though, the more advanced thing to learn is what you do when there's more bone? Because maybe the answer isn't just to get rid of it, right? So like one of the main things when I was first learning about FP1 versus FP3, which is, FP1 is usually just kind of it gets glossed over, leave it to the prosthodontist, don't worry about it, right? Is what if you have a patient that has a high smile line? And that used to be an indication in my mind, you shouldn't do FP1 because you don't want the gums to be visible, right? We're supposed to hide our work, right? But one thing I've been sold on with you guys is that no, that does not mean you need to do FP3. In fact, that's one of the worst things you could do, because now you're going to be removing even more. You're going to remove 15, 20 millimeters to try and make this case work and try and fit into the FP3 world. And so we've seen tons of cases, some of them live today, like in the chair, that had high smile lines. And either you preserve that, and this is entirely based off of patient expectations of what they wanted, or you reduced it and actually left some gum on purpose and made it absolutely beautiful and harmonious without even actually removing that much bone. So can you guys talk a little bit about how 3-on-6 approaches those high smile line cases, how you're able to plan for that? What's the approach like? How much bone does get removed? How does the prosthetic make that work?
Yeah, so the way we generally train it, a lot of it depends on how much of a gummy smile they have, how high that smile line is, where we want the teeth to end up. But a lot of doctors come to us and they ask for like a bone reduction guide, something to help them create that architecture. And I often have to steer them away from doing something as macro. We talk about micro and macro. Doing something as macro as that, because really what we try and do is we use our prosthetics. Our lab is trained to create pontic sites, to create natural looking aesthetics. We want to use the prosthetic to guide the development of the bone and the tissue. So oftentimes in the cases that we did, we are removing very, very little bone or none at all. Maybe we're just putting the prosthetic right at the bone level. And what that does over time, as we suture the tissue to the prosthetic, it's going to allow resorption on its own, and we get rid of a gummy smile without taking a burden.
It's a guided bone degeneration.
Yes.
So really,
Guided bone loss.
Yeah, that's right.
so really we're shooting for the incisal edge where we want that to be.
Yeah.
And then we're going up from there for what the ideal teeth shape and length are. And so we're going to say, okay, this is where I want the incisal edge. And then the lab will plan the rest of it up from there. So, and we're using our Instarisa scan so that we can know exactly where their smile is with their picture, where it is in their bone, so that we can map that all out before we start. So then we have our ideal teeth with their ideal shape and size, and that's going to be adjusted depending on the size and shape of the patient's mouth and their lips. And so normally we're going over that with our patient or with our lab before we'll even start placing the implants in the surgical guide. So we start with the prosthetic, we start with where the incisal edge is, and then we will start with that design. Once we know exactly where the teeth are going to go, then we're going to start designing the implants, and so that we can start knowing exactly what angulation those implants need to be in, so that they can, so that the screws can be coming out at just the right spot.
And what depth?
And what depth the
Which
implants
allows
will
us
be.
to then guide that.
To then raise that smile line, raise that
Yeah,
cavity.
I had a periodontist in the military that taught me that you can either do clinical crown lengthening with a burr, or you can do it by invading the biological width.
Yeah.
Right, and that's what you're
It's
talking
essentially
about. Yeah. So
Right.
you just invade that. You put pressure on the bone. The body's going to respond accurately. It's going to reestablish the biological width, with the attempting to get that 3 millimeters of gingival tissue. So.
Yeah, and we had two of those cases today, your case and one of ours from our training patient 3 months ago. And say we didn't, I don't know if you took a burr to yours, but during the training, we didn't touch the bone at all. And you saw the reduction in how much gum she was showing when she smiled. It's purely based on the prosthetic alone.
On mine, she had about 6 millimeters of gum showing when she was smiling beforehand, and I removed about 2 millimeters. And on her bone was coming out pretty far at an angle facially, so taking off 2 millimeters brought it out, brought it back and brought it down. So, but anyways, it made a much more aesthetic
Yeah.
smile.
I think that case too, because that was kind of one of those aha moments for me, is looking at the results that you were able to obtain on that case. Because she had excessive lip support, right?
Yeah.
And you reduced that 2 millimeters from a buccal lingual or buccal palatal dimension. And then I think it also allowed her lip to relax a little bit more, and it gained a little bit of length by doing that. So she had a little bit less gingival show. And
Right.
that was so beautiful. She looked amazing. Her before and after is probably one of the most beautiful
That's really
ones that you could see. So
Seriously.
Thank you.
If you're considering restorative dentistry with dental implants, you should know all of your options. Head to 3on6.com and book a free consultation with a 3on6 provider near you. If you enjoyed this content, please like, subscribe, share, or leave a review in the comments. Until next time, keep smiling.